This is Jim Crawford. I will be host of this webinar. This is one of a series of webinars of the Patient-Centered Primary Care Collaborative that is sponsored by the Center for Care Delivery and Integration. I should also note that this webinar marks the launch of the PCPCC eHealth Special Interest Group, which is a continuation of the former Center for eHealth Information Adoption and Exchange, and of which I'm serving as a co-chair. That center, now a special interest group, is aligned now with the newer Center for Care Delivery and Integration. For those of you who are interested in pursuing the thread of eHealth, our next eHealth call is Tuesday, June 4th at noon Eastern Time. You can find information on the website either through the calendar or through the stakeholder tab on the PCPCC website. I also want to encourage you to register for the PCPCC Fall Summit being held October 13th to 15th in Bethesda. There will be a dedicated workshop on eHealth. And my last public service announcement is to let you know about the Thursday, 30th of May National Briefing. That'll be at 11 Eastern Time, again on the PCPCC calendar. This will be an hour spent with Art Kellerman discussing his recent January 2013 Health Affairs article on achieving the as yet unfulfilled promises of health IT. But for today, we will have a webinar entitled Meeting Patients Where They Are, a Medical Home Model for High-Risk Patients. The speakers are Dr. David Moen, who is president of Bluestone Solutions, Hope Summers, director of sales and marketing, and Seasons of Maplewood and Ecumen community, and then lastly Trish Pitcher, director of marketing and community relations for Bluestone Physician Services. And I will let the speakers introduce their topic and go from there. David?
Good morning. Thanks for giving us this opportunity. This is Dave Moen, and I'm joined by Trish Pitcher, who is here with me, and Hope, who will be joining us shortly. Today we're going to talk about a model that has been developed in the Twin Cities since 2006 and has grown to be a substantial contributor to this community in terms of our efforts to improve the family experience, the patient experience, and also reduce cost of care and improve clinical outcomes for high-risk patients. Our intention is to, trying to get the slide to go. Is to really describe what it is that is allowing this on-site care model for primary care to really differentiate for these high-risk patients. Why we're seeing the level of performance we are, we believe relates to the way our teams are configured, the emphasis on relationships with the patient and their support network, be it the staff at the facility and very often family members who are involved in decision-making regarding their care. The ability to be very responsive and resilient in the way that we structure our care planning so that we prevent unwanted and unnecessary utilization that happens with high-risk patients if everybody's not on the same page. So we've made some efforts to develop tools to really drive a very resilient care planning process for these patients. And then we also have used technology-enabled efficiencies. A lot of technology that's used in healthcare today, the EHR specifically, is designed to enhance billing and documentation, and sometimes provider efficiency is not the primary objective. The technologies we use are designed to facilitate cross-functional team activity. Provider efficiency is the primary goal in terms of how we can communicate with each other, but also how we engage families and patients and staff and team members caring for patients in the execution of care that needs to happen. So there's less emphasis on increasing revenue per visit types of activities that many EHRs construct their entire business case on, and more emphasis on provider-based efficiency. The other thing is Hope and Trish will be talking specifically about the patient, family, and staff and provider team experiences. Hope works in a facility that we serve that has a large population of high-need patients, and she's also been a family member of one of our patients, and so has a perspective of both being in the facility, working with patients, and being a family member. And Trish's role is to be out in the facilities on behalf of our company, relating to the staff at the facilities, understanding what their concerns are, holding family nights for family members to get to know the model, to understand the model, to provide feedback, also helping us with a patient and family advisory committee that we have that provides feedback on an ongoing basis as we continue to refine and improve what we do. So there will be a middle section where we'll have Hope and Trish really talk about the experiences from their perspective being out in the field as a user of our model. And then after the middle section, talking about those experiences, and we'll welcome you to send in questions along the way, and we'll address those along the way if you have them. We'll then move on to describing the measurement framework. So what do we measure, and what kind of results are we seeing at this stage of the game? And then we'll plan to share where we're taking this model. In the Twin Cities right now, we have about 5,500 patients in our two care models that serve both patients living in assisted living, group home communities, and also a care coordination model that serves high-risk patients in their home. Today we're going to focus on the on-site primary care model in the group home and assisted living setting. So we consider this Twin Cities practice to be a sandbox. It's a place where we test different technologies, different kinds of team configurations, and different kinds of behavioral management techniques in order to continue to develop this practice. And what we're doing is taking our experience having built this since 2006 in the Twin Cities, and we're now scaling this model to other health systems and other markets who have a desire to serve this very high-risk population that's very challenging in an efficient and effective way. So I think everyone is familiar with where we need to go or where we're going in terms of our care model and payment model. On this slide, we really show down in the lower left that we're moving from the individual fee-for-service system that's based on counting numbers of procedures and billing for services in that fashion to really trying to define value, and we define it in terms of the triple aim being high quality, great experience, and the lowest cost possible is defining value, and really trying to provide value over the course of a lifetime. And in order to do that, we're really needing to and facilitating the transformation to payment models that are structured to incent that kind of outcome. And we see right now that we're in this, what we would call yellow box, where we're transitioning from fee-for-service to these more global payment models and looking less at providing a service for a patient and trying to provide an experience and an outcome for a person over their lifetime. So this slide just characterizes that switch from today's payment and care model to where we're heading. And we believe this is a natural transition that needs to occur, and our model, we think, helps organizations make that transition more effectively. So let's start by talking about the population of patients that we serve. I think everyone knows that there's a small number of patients that account for a huge number of the resources expended in healthcare today. And we find that within that population of patients, there's a high utilization in year one that naturally regresses to the mean in year two. And this is really an important point. A lot of the clinic-based medical home work, we find, addresses this part of the high-cost population that has acute episodes that need to be managed very well, or they have chronic disease that needs to be managed well, and there's costs associated with people in that group of patients. But those are not the patients that we tend to focus on. So we're talking about a population of patients that in general is not coming to the clinic, or when they're coming to the clinic, they tend to be very difficult to care for because of disabilities or because of dementia or other complicating factors which make trips to the clinic very difficult. One of the things we use to describe our population is that our patients take longer to get from the waiting room to the exam room than they do to spend time in the exam room. And I think that's a really important point. So this care model doesn't conflict with or compete with medical homework that's taking place in the clinic. That's a critical part of the work. But our population is actually a population that's difficult to reach. And it tends to be patients who have very complex social, behavioral, and medical needs. They also tend to have a chronic high spend. The population that the clinic medical home does really well with, from my perspective, are patients that have a chronic condition but still are capable of getting to the clinic, and great management of those patients yields better outcomes and lower costs. The population we focus on are patients that in year 2, 3, and 4, despite great medical homework, continue to be difficult patients to manage. And it really is that combination of social, behavioral, and medical needs that make this population particularly difficult to serve in the clinic setting. What we find with our group of patients is a higher percentage of these patients are on public programs of one type or another. The majority of our patients are Medicare patients, obviously over age 65. A good section of our patients are on Medicare Advantage plans. A good portion are on straight Medicare, and a number of them are also dually eligible patients on Medicare and Medicaid. Our patients tend to be frail. Many are elderly. In our on-site practices, our average age of our patient is 86, and their average life expectancy is under 2 years. In our care coordination practice, which is in-home model, our ages are not there. They're younger, but this population we're going to talk about today tends to be a frail elderly population. We also see a very high incidence of dementia. And what we've learned is that because of the way the clinic and hospital systems are structured today, and because of the difficulty of these patients accessing care, this population is actually underserved, which I think is comes as a surprise to lots of people. And we find by improving service, we're actually able to lower costs because of the fact that these patients aren't getting the services that they need. So our model is really designed for the highest of the high risk. So that 13% of high spenders in year 1 that remain high spenders in year 2 is the population we focus on. And again, we have 2 models that we use that are highly complementary and integrated. And today we're going to focus on the facility-based model, which serves our assisted living and group home communities. which we call the Bluestone Vista model, which is a true primary care model where we assume primary care for these patients. Our clinicians become their primary care doctors and nurse practitioners. The population, or the care model on the left, the high-risk care coordination model, which is not based in facilities, is directed at similar patients, but they're residing in their homes. And in this model, we do not generally assume primary care, but we assure that these patients have great primary care. And what we try to do is defragment and integrate the experience they're having with their current providers. And we do provide some medical oversight. You see the MD services do extend over into that population. But we have a very small involvement there, which is similar to how a hospice physician would work within a hospice program and with primary care physicians. It's really an oversight role, which is focused on optimizing medication management, behavior management, and dementia management as the core capabilities of the physicians that oversee the care coordination program and assure that we have optimal plans in place around those high-risk areas. So going to the on-site care model, which we currently are in over 140 facilities in the Minneapolis-St. Paul area, and the model has doubled in size nearly every year through 2012, so it's been an extremely popular care delivery model. In the traditional model, the physicians reside at the hospital and clinic, and the remainder of the care team does their work in the residential facility. And what we've done is taken the physician capability and moved it so that it is working in support of and operationally integrated with the critical services that are needed in these high-risk settings. In our market, we're focused on the assisted living and group home population primarily because there were not physicians in those environments when this was started in 2006. This model can also be used very effectively in nursing home environments, but we have not chosen to be there because there are already clinicians in those settings doing great work, and there was a great need for us to move rapidly and serve this population in the assisted living and nursing home environment, or I'm sorry, group home environment. One of the keys about our entire model is that bringing the physician on site and integrating with the services there makes this a much better experience for the patient, but it also makes it a more integrated experience for all the services that come into these settings. What we've learned in the last 6 years is that as patients progress in their frailty, additional services like home care, often hospice, often DME, sometimes care coordination from specialty services and other types of physician services working with the patient, all are coming in and out of these facilities. And if you have 4 different care delivery systems working in one facility and 5 or 6 hospice agencies and 3 or 4 home care agencies and different DME providers and different pharmacists, it gets to be a very complicated environment for a director of nursing in an assisted living or group home to manage. And what we've seen is there's high turnover among staff at these facilities and low satisfaction because of some of the complexity of trying to manage multiple players serving what really is a community that really demands and responds to an integrated care model. So again, when we bring the physicians on site, we really look at the care in its entirety. So we look at what are the programs that need to be in place. As an example, have been in a group home setting, and when we analyzed their emergency department utilization, 40% of that utilization was due to abdominal pain in the emergency department, of which the root cause was constipation. And by putting a bowel program in and making sure we manage the medications appropriately in this population, we had a 90% reduction in emergency department visits. So we find that as we get into these settings, we really are looking not just at the care of the individual patient, but we're really looking at all the components that need to be there for the patient and beginning to align care to the best practices that you really need to support in these settings. So programs around bowel management, around fall reduction and fall assessment, around management of infections, end up being very critical in addition to how we manage behavior. What I've found as an emergency physician now practicing in this team-based environment is that there are many, many sick and complicated patients in these environments. And I reflect on my emergency department experience. I would often see these patients coming into the emergency department, and they would be very complicated, and when I was seeing them, I often didn't have much of the information I needed to make a good decision. And there's high utilization because of the variability in the staff that are staffing these environments, in the responsiveness of the physicians caring for these patients in the traditional way, and because of the variation in programs and nursing care that is available on site. So we've found by really driving the entire model at the facility level, and integrating services and standardizing practice, and then making a very responsive clinician model, that we've been able to drive down utilization. I think it has all to do with looking at the whole facility as the customer in addition to each individual patient. So when we look at why this type of care is differentiating, I think a couple things are happening. One, we have a different predictive model, and we find patients at the right time. If you think of why patients move into an assisted living environment, it's usually because of a social factor of one type or another. It's generally not because of a hospitalization. And if you think of predictive models that health plans use to decide who is high risk, often that's triggered by levels of utilization. So what we see in our model is we end up doing what we call pre-acute care instead of post-acute care, because our model actually connects with patients when they become more frail, and when, from a social perspective, they're less able to be independent. And that's really a key part of our care model, is that I think we find patients earlier and we prevent some of the downstream complications that come if we wait until we have more of a post-acute model. The other thing that differentiates this model is the way the teams operate. Each physician has 4 support team members, and that allows our physicians to spend 45 minutes to an hour with a family having a care conference if that is needed, and other team members are able to pick up and continue to keep the practice moving forward so that we can still see a wide enough number of patients to keep the practice thriving from a financial perspective, but also continue to reach and touch the number of lives that we really need to with the limited number of clinicians that are available in this space. The other thing, I think, care migrating to where patients live, we call that care migrating to the patient's life geography, is a key part of the model. What I found in the emergency department as I was practicing is that many of the patients that I saw were having difficulty accessing the 9 to 5 clinic schedule, because they were often reliant on one of their kids bringing them to the clinic. And the kids are working. And so it just became very problematic. Another thing I saw a lot on holidays was a daughter would come to see her mother and bring her to the emergency department because no one's open on a holiday, and that's the day she went to visit, and she didn't think her mother looked very good, and she talked to the staff, and the staff didn't, it's a holiday, so the people who are usually there may not be there, and we ended up with a person in the emergency department with very little information. So I think, again, the fact that we're on site and we're proactively addressing these issues and engaging the family has had a huge impact. The other thing that I mentioned earlier, I'll just reinforce again, is that really the corridors of focus have to do with dementia, behavior management, and medication management as key clinical focus areas. And then finally, technology. It's very important to talk about the technology piece, because without transformative technologies, I don't think we can gain the efficiency that's really needed to make this model work. So we use a communication portal, and that is a portal that allows family members to sign up to submit questions or receive email summaries of visits. It allows us to do order entry and respond to requests from the facility staff if they need an order for a med refill, or they have an urgent request for because someone has taken a fall or their status has changed. And what our portal does is help us be responsive and manage the huge amount of communication that goes on in this population. What we've seen over the last 6 years is that there's 3 touches through our communication portal for every face-to-face visit. And when I think about the clinic and seeing these patients in the clinic, a lot of that work is not reimbursed and isn't the primary focus of what we do in the clinic setting. It also tends to end up being shifted from the front desk to a nurse to the doc's inbox, and often doesn't end up with a level of priority that results in the best outcome. And so I have really come to appreciate the importance of technology. The other technology that we use allows us to email a family member and allow them to participate in a care conference if they're not on site. And we've had examples of family members in other states who've been able to participate in care conferences. And what that does is help us prevent the Saturday night daughter in California syndrome, which in Minnesota sometimes leads to an emergency visit and care that may not be what everybody has agreed on, but an uninformed family member is insisting upon. And what we try to do is understand the support network of a patient and then engage them proactively in the care planning process. And we use technology to facilitate that, because today not everybody can be there on a Tuesday afternoon at 2 o'clock for a care conference. Yet we need people to participate. The other places where this technology has been tested in the Twin Cities is bringing pharmacists on site through the web to do specific med management work with patients and their families. And this has been incredibly helpful in terms of distributing, again, an expensive and limited resource, the pharmacists with geriatric med management capability, to multiple locations. And that's very hard to do if they're spending their time on the windshield. So, and we found this to be embraced and accepted by residents in these facilities. Many people think that older people won't use technology. What we find is when it's facilitated in the right way, it can be a very valuable add, and patients have no trouble at all talking to somebody on our laptops, which is where that occurs. So it's been a great add. We also do behavioral health consults through this technology, and I see this as continuing to expand as we go forward. So I think we'll move on and invite Hope and Trish into the conversation. I'm going to start with Trish. Trish, maybe you could describe a little bit of your history at Bluestone, maybe describe your role and tell us some of the things that you've learned as you've watched this model grow. And I also encourage folks to submit any questions you might have along the way, and we'll see if we can link those into our discussion.
Sure. Thank you for having me. I am Trish Pitcher, and I do marketing and community relations for Bluestone Physician Services. And Bluestone Physician Services is really the original VISTA model. And a big part of my role that I do is not so much the marketing, but what I really want to focus on is the community relations piece. And as to what Dave said, our relationships with the facility staff and the family members is a huge part of making our model successful. So what I do is I work with our 7 teams very closely and our 140 to 150 communities that we partner with, and I make sure that they have the resources and the support that they need to work with our teams. And I do this by providing ongoing education on the Bluestone Bridge, which is our communication portal. We do this by offering CEUs for the nursing staff, specifically focused on the assisted living community nursing staff. Those nurses are really the eyes and ears that make our model successful in building that partnership with the nursing staff and our provider teams. So those nurses and the facility staff don't feel like an island out there, and letting them know how and when to appropriately contact the provider team and knowing that they are a support system for them. We do this in ways offering nursing forums with the free CEUs. We do quarterly newsletters and quarterly meetings where we sit down with the staff and ask, what is it that we can do for you as a team? And just by having those conversations and that dialogue and letting them know that they're supported by this team is a huge part in making this model successful. Another key piece to what we do is involving our families. Family engagement and building that relationship with the family is another key aspect of making our model successful and what we feel really sets us apart. And we do this by offering family nights and educating our families, doing newsletters to families, and also by families who choose to register on our communication portal. After each visit, we send them a message, a secure message, informing them as to what happened at that visit that day with the loved one. So by keeping families informed, it really decreases a mixed message from the facility staff and the providers, so that everyone is in the same communication as to what's going on with these patients. So those are just a few things that I do for Bluestone Physician Services to really engage the staff and the family members to make them feel part of this team and a key in making this model successful.
Great. Trish, can you talk about when you go to conferences and people hear about this model that are in this industry, what are you finding from facilities that don't have this model in place that are hearing about it? What's the buzz out there?
Well, one of the main things is they can't believe what we like to call here is relative responsiveness, the capability to have access to that provider team. Oftentimes when I say, here's the provider's cell phone number, call them, that's the one thing that they really, it's kind of the awe factor for these folks, is that they get that direct access to the providers, and they don't wait 3 to 5 days for a response from the clinician.
And as you look at the provider teams, we could probably spend just a few minutes talking about the team itself. Teams are led by physicians. The other team members are 1 to 2 nurse practitioners, and then team coordinators, which what I've learned practicing in the model is really an essential role. Maybe you could talk a little bit about the team coordinator role, what you see as important there, and that's probably the role that I have come to appreciate the most and also understand how key it is.
Sure. The team coordinator position is a non-clinical position, part of the team, and it's really what I like to call the glue that keeps the team together. They handle all the scheduling, all of the paper, non-clinical aspects for the team, and really a liaison with the facility staff too, and the family members. So there's always someone immediately that the facility staff and the family have access to the team, and really a support system for the team and the facility staff.
Great. And then can you talk a little bit about what you've seen since you've been here in terms of the growth? What do you think is the key to why this model has grown so rapidly?
I think it's the fact that we are providing good patient-centered care, and that we are involving the facility staff and the family, and they all feel part of it, and they feel heard and recognized for the work that they're doing, and for their questions and concerns about their loved ones. And it's just a good delivery of care. And it's different. The one thing, I've been with the company now 2 years, it takes people a little while to understand that, yes, we are seeing your patient or your family member on a monthly visit, and the benefits of that monthly visit. Sometimes there's a question, why do you see them monthly? But after this happens for about 3 months, they see that the quality of life has increased for their loved one, and the relationship with the nursing staff, getting to know that provider team when they're in there once or twice a month, and building that relationship with them, it makes their life so much easier because they have that direct access to that provider team, and everybody knows what's going on with that patient, and they all can provide the best care for that patient. And I think that that really, when people understand that and they see the benefits of it, that's what really makes this model grow.
I've noticed the family members, just the burden of taking people out of the facility for clinic visits and then being called when there's emergencies and going to emergency departments and then ending up in the hospital. It's just a tremendous burden for families, and they feel a tremendous lift when there's somebody that they can rely on and communicate with that is taking a higher level of responsibility for the clinical aspects of care. One of the things I've noticed in the assisted living world is that I think these facilities really grew up as real estate investments with sort of an apartment building model. And I think what is apparent is the public has a different expectation. And I think that when the public takes a patient into a facility like this, I truly believe that they expect that there are clinical capabilities there. And in my experience, they expect more than I believe was initially designed to be there. But I think the evolution of the marketplace in long-term care has placed more and more patients in these types of facilities when they have multiple chronic conditions, advanced stages of dementia, and they become really very high-risk patients. And so the real estate model doesn't work very well for that patient population, so we end up with high emergency department and other utilization that I think is not adding value. I would say one of the things that's been most impressive to me as an emergency physician when I saw these patients, and we've seen this in our data, is that 60% of these patients, if they present to an emergency department, end up admitted to the hospital. Each hospital admission averages $18,000. What I saw in my experience was that many times the admission was not so much because there was an acute medical condition going on. It usually was a combination of multiple chronic conditions an unknown baseline, an uncertainty about what I was discharging the patient to back into the community. Also payment models, meaning Medicare wouldn't pay for ambulance to take someone back to these facilities because it's going back to their home. So transportation was an issue. Lack of information available at the time of the visit made this really, really difficult to manage in an emergency department setting. So the high admission rate, I don't think, is justified by the acute nature of the condition these people are experiencing. I think it's an intersection of chronic disease that's maybe not been managed optimally, a lack of knowledge and infrastructure to discharge these patients back to the assisted living or group home setting, and then the path of least resistance is put them in the hospital. And we have seen multiple instances of these patients getting into the hospital and ending up with Clostridium difficile, head injuries from falls, escalated dementia, worsening chronic conditions, and discharged back, not back to the assisted living, but into the transitional care and sometimes skilled nursing environment. And it sets off a whole chain of events that really the patient, instead of coming into the hospital and getting better, comes into the hospital and gets worse. Family members have told us that they don't want their family in the hospital if possible. And they, too, see that hospitalizations in this population are very, very hard on the patient, and they're very difficult for families to manage. So I think that, again, the model itself takes care of a problem, and it's not about denying people access to something they need at all. In fact, it's preventing them from accessing a part of the system that becomes dangerous as we become frail and elderly, and really supplementing environments that are more appropriate for these patients and providing a better model of care in that setting. So it looks to me like Trish and I are here and Hope's not here. And so I think what I'm going to do is move on. I also would invite any questions. If you have questions, please send those in. We will be happy to answer those. I'm just going to click and see. Looks like we've got a question here. So one question is, what kind of documentation tools do we use? In our practice, in addition to the communication portal, we use an electronic health record called Amazing Charts. And our portal is not an electronic health record. It integrates with the health records that are in use in the community. So as we work with a system like Fairview, we actually use Epic, or their clinicians use Epic as the documentation tool, but in our clinical practice, we use Amazing Charts. So Trish, maybe if you want to handle the questions.
Sure.
Finding the questions. I'm going to go on as we wait for Hope and talk a little bit more about how we measure our effectiveness. So just reviewing the business cases, why does this model work? And it does work in a fee-for-service system. It's because we actually leverage geographic efficiency, which means that when we have patients aggregated in the community in these settings, our clinicians can be efficient in serving those patients. I think the way the team and technology work together, both for the clinicians and for the other support staff and family involved in the decision making and the care delivery, that's a key component. And the other thing that really helps us drive our performance is being able to bill for care plan oversight, which is a Medicare code. And when we're seeing patients that are this complex and we have 3 communications for every visit, that we truly are able to document and demonstrate that this is an oversight of an ongoing care plan. It's not just a single visit. The other thing, in our state, we're allowed to bill for medical home care. It's a fee-for-service code that's added. It's not a very, very big fee, but we're able to demonstrate that this meets all the criteria to be a medical home. In fact, Bluestone Physician Services was the first geriatric medical home certified in our state and perhaps even nationally. And in terms of the total cost of care performance, where we're really seeing the decreased cost is the decreased emergency department, hospital admission and readmission. And then we're also seeing, when we add the care coordination model in the home, we're seeing that people are able to stay in their own homes longer, and we're slowing the progression to facility-based care, whether it be in the assisted living or in the skilled nursing facilities. So really, it's a combination of those two things that are really helping us reduce costs. When you look at the care of a person with dementia, it averages about $41,000 to $56,000 per year, and about 70% of that cost is not hospital, emergency department, or physician costs. It's actually facility costs and other service delivery costs to support these patients. So if we can slow the progression into the facility part of the equation, and we can really support these people in their own home, we get a diminished cost overall. So fortunately, Hope just joined us. We were hoping you'd join us.
Well, I'm so glad to be here.
Yeah, so let's reintroduce Hope. Maybe slide back. Hope, maybe you can tell us a little bit about your background, okay, and how you've intersected with the Bluestone model.
Okay. Well, my background started actually taking care of my parents in my home for about 10 years. My dad with Parkinson's, my mom with dementia. My dad passed away at home, and that kind of launched me into the caregiving role, if you will. On a professional level, I became a manager of a housing community, small, that eventually my mom moved into. And that's where I was introduced to Bluestone, actually, Dr. Siblin, which was an awesome experience from beginning to end. And Dr. Logan kind of came in and took over because Dr. Siblin was moving on in other places. And so my experience, first and foremost as the daughter role, really speaks to my heart, knowing my mom's dementia was a progressive disease, of course, watching my own mom slip away, and just how to bridge that gap between being the daughter, being the housing manager of that community, and letting my heart be where it needed to be at the time it needed to be. So I always speak to it first from the family side.
Yeah.
Absolutely love the option to be able to talk to a physician, whether it be email, voicemail. Dr. Logan, I'll praise him, but he would get back to me within 15 minutes of a phone call or an email. My own physician doesn't do that yet after 30 years. So there's a sense of comfort there. There's a confidence that's just naturally built in, knowing that my mom was in a good care and had good physician care as well.
Great. That's a great perspective. And then from a facility perspective, now that you're working in a larger facility, how big is Seasons of Maplewood?
Seasons of Maplewood is 150 units, independent senior housing, assisted living, and memory care.
Okay. And how many of those patients are seen by Bluestone physicians?
Oh my gosh. I want to say probably 70%.
Yeah. And Trish, is that typical that we generally cover the majority of patients in a facility over time?
Yeah, typically in a memory care, we see 90 to 100% of the patients, and in an assisted living facility, it's usually around 80 to 90%. Mm-hmm.
And Hope, when you, why do you think the model has grown within your facility? What's the buzz?
What's the buzz? Well, I actually share my personal experience with every family member that I tour and introduce to the services that not only we provide, but that Bluestone provides. And so I can sing praises to it again from that experience. It's amazing. On the back of my desk is a picture of my mom with the card from Dr. Logan that I kind of hold up as my little banner, that at her passing, I received this personal note and thanking me for the honor of caring for my mom, and it just resounds in my heart.
That's great. These are all key parts of the model. One of the things I've seen that is so incredibly important is as we see patients in the model over time, we develop trust with the family and with the staff, and that trust ends up being extremely important when we hit the more difficult parts of the aging continuum, when the difficult conversations need to take place. To have that level of trust built makes that whole part of the experience go better on our side, I know for sure, and I'm guessing on the family side as well.
Absolutely.
Yeah. So that's great. Trish, can you think of anything else that we would want Hope to mention before we move on?
Can you talk a little bit about any feedback that you get from the nursing staff there and the benefits to the boots on the ground nursing staff?
Well, I think the number one feedback that I hear from our nurses is the fact that that connectivity is there. It's just instantaneous if they need anything. Voicemail, again, email, any connection that they need. And, of course, that helps us deliver excellent care as well. So it's a collaborative effort, to be sure.
Great. All right. There's a question here that I think is really a good question. So could you share more information about the predictive model? And it is such a key part of what we've learned. However, and the question is it commercially available or was it developed in-house? It's developed in-house, and it's not commercially available. And at this stage, we aren't saying a lot about it because we're still refining and building the metrics around it. What I'll say is that in general terms, it just comes down to what are the things that cause people to lose their independence, and how do you measure that? How do you find those patients sooner rather than later? And there are a number of things that we're experimenting with around that. But I would say that to say it simply, it focuses more on social factors than it does on medical utilization. And I think in this population in particular, the social aspect of people's lives is what really begins to drive utilization when some of the social framework falls out from underneath the family or the patient. And so that's about what I have to say about the predictive model. So back to the business cases, I think we had started on this. I don't think there's much more to say other than in terms of the geographic issue, what we do is look at the geography of a marketplace and then figure out what number of teams would we need to cover that geography. And in my experience, working with health plans and in healthcare systems, that is not the way that we traditionally think in those venues. And so what I think is critical in terms of the efficiency is that we try to really focus on understanding where these patients are concentrated in the community and understanding how to best utilize clinical resources to meet that need. To me, it doesn't make a lot of sense for 3 health systems to be driving around, coming into one facility and leaving, and then driving to the same facility 20 miles away and seeing patients, and driving in somewhere else and seeing patients. The people who are run ragged in that model happen to be patients and families and clinicians. And it feels to me like those are the most important people we need to be paying attention to in terms of the experience. So what we really try to do is have the model stay intact in a community by partnering and collaborating with health systems, with health plans, and with facilities to deploy the right number of teams to serve a community in that geography. That's a big leap for health systems and health plans who are traditionally competing for business. To be thinking more collaboratively to drive efficiency is a leap. I, however, think it's an important leap and critical if we're trying to meet the need of a rapidly growing population with a small group of providers. We have got to think differently about how we work together to meet the need, and I think that's really important. So in terms of how we measure our success, what we like to measure are things like what % of our patients have had advanced care plan completion. We use a PULSE form, which is very specific in terms of giving us direction. And this has been embraced in our community by the health systems. In the assisted living community, it's not yet embraced, but we're working to really get a unified measurement tool out into these communities. And also what we'd like to do is make sure that 100% of our patients have had the important care planning discussion and that we've gotten all of the support network on board. The other quality indicators we look at have to do with disease management. So we really look at specific conditions, dementia, behavior, diabetes in particular, and we look to optimize management. One of the challenging things that we've faced is in our state we have very advanced measurement for clinical practices, and they've been designed for typical clinic practices. So measuring the D5 for diabetes makes sense in a 50-year-old, but in most of our population, achieving the D5 is not exactly what serves them best. And so we've been working with our state and with Minnesota Community Measures and other organizations to really define what are the optimal care measures for this more late-stage population. And we've got a lot of work to do there, but we're really trying to focus on what's appropriate and what is not just busy work, but what really differentiates the model. So medication management is huge. What we find as these patients come into our practice is they're on multiple meds, and we spend a lot of time discontinuing medications. And one of the things that's been very striking to me is how many meds we can discontinue with very little impact and actually improvement in the patient's health. A lot of these patients come in on 3 or 4 meds for hypertension. Many times they've not been compliant on these medications. They get in a setting where they're being administered medications, and all of a sudden things go haywire. And so I think there's a couple things at play here. One, when the patient's at home trying to manage 24 medications, it's likely they're not taking them as directed or prescribed. And 2, there's a lot of just miscommunication and between various specialists and formularies and insurance plans about what these people are on. So the medication management ends up being a huge issue, and we find we're discontinuing lots of medications, and I'm amazed how, after patients have been in our practice, how much their medication lists actually get trimmed down. I think where the most difficult management of these patients comes to play is really in the behavioral realm, and maybe Hope, you could talk a little bit about this from the facility perspective. We really try to not use sedatives and antipsychotics and antidepressants as much as we possibly can, yet there still seems to be a role for some of these medications in this population that is not in a skilled nursing facility yet still has dementia. What's your perspective about the sedatives and antipsychotics and antidepressants and the use of those medicines in this population?
Well, Ecumen has a program called the Awakenings Program, as you're probably well aware, and their goal is ultimately to take those psychotic medications away as much as possible and replace that with more care, resident assistant care, more building the relationship foundation.
Yep.
And it's been just a great program for us.
One of the things, there's been some neat research done that I'm trying to think of a company here in the Twin Cities, but I know that what they've discovered is that as really when we're looking at a patient with behavioral issues as they age, it comes down to 4 corridors: boredom, a sense of lack of purpose, loneliness, and fear. And it seems like if we can get our arms around understanding what are the drivers of the behavior, which takes a relationship, it takes trust, and it takes time, which I think is very difficult. However, downstream, if you can get your arms around, is it boredom, is it loneliness, is it fear, is it really a sense of lack of purpose? Which of those is it, or what combination of those, and how do we begin addressing those things? And that seems to resonate with the Awakenings program as much about trying to proactively address the person's life and not medicate over the top of it, so to speak.
Exactly.
I do find, though, as a clinician practicing in this model, there still are patients that it seems at certain stages of dementia in particular, when there's more anxiety, that sometimes medication is necessary.
I would agree with that. Mm-hmm.
And I think what we try to do is, 1, keep doses very low, and 2, really monitor patients closely when they're in that type of, when they have that kind of need, and try to really make sure that when we're using these medicines that patients have truly gotten better. And sometimes, quote unquote, easier to care for doesn't necessarily mean better, because people can be over-sedated in these environments as well. But I would just say, as a physician practicing, this is probably the most difficult part for me, is understanding when to prescribe medication, when to ask for more from staff in terms of support, and when to ask more from family, and how we make that decision, I think, is really nuanced and difficult and requires some trial and error and seeing if people are better or worse after a test dose sometimes is really the only way sometimes we figure that out. Mm-hmm. Any other comments about behavioral management or behavioral issues in this population?
I think just knowing that particular patient or that resident is key, and having family involvement is very helpful.
Yeah. I've found families are really interesting with regard to this issue. Some families really want their family members quote unquote comfortable, which to me looks more like sedation. Other family members are really upset if they think that their parents are too sleepy. And it really is a balance, and it is understanding what the family expects and really how the patient performs best in the environment. But that takes a relationship, and it takes time.
And I think it also takes education. You have to educate that family member or members on where that patient is in their path, shall we say.
Yeah.
And knowing, kind of going forward for that family member that there's a declining or progressive disease, and that what you see today is not necessarily what you're going to see 6 weeks from now. And it's helpful to have that educational piece from the physician.
I agree, and I found it useful to talk about birth in reverse. I think that there's stages of dementia that look like the terrible twos, and there are stages of dementia that look like an early infant stage as it really gets progressed. And I found it helpful to talk to families about the same thing, that this is a continuum. We're going to see changing behaviors, and our job is to manage those to the best of our ability. Like a baby, it can be sometimes hard to sort out when the crying is due to hunger, due to a wet diaper, due to whatever, and we aren't going to make the right choice every time, just like with a baby. The hard thing is with a baby, they tend to be growing forward instead of growing backwards, and this is mixed in some grieving, which makes it emotionally just a much more difficult transition. However, I found that to be a helpful way to talk about it if it can be done respectfully, of course. So other measures that we're really interested in is days out of the setting, and what we found, especially in the group home environment, is that our patients end up not going to hospital, ending up in skilled nursing, and then being out of the facility for days or weeks at a time and then coming back. And with certain payment structures, it can really impact the financial performance of a facility if patients are bumping in and out of the facility. And we've found a dramatic decrease in days out of the assisted living setting in the model when we have this on-site care, which tends to be a real value proposition to the facility itself. Would you say in your setting you've noticed a difference in terms of days out of the facility? Do you think you've seen that in the AL population like we have in the group home, or have you not really noticed that?
I have not noticed that.
Okay. I think that is more applicable perhaps in the group home setting, but I do think it impacts this population and some of the facilities that we're in. The other thing that we measure is what percentage of deaths are occurring in this setting. And what we try to do is have people die in the way that they want to die. And what I've found is most people don't want to die alone, and they generally don't want to die in the hospital. And they'd like to die in the presence of their family. And that's a challenge if you're bouncing in and out of hospitals and ERs. We find that about over 95% of our patients actually die in the assisted living setting, which I think is an important metric because that's what our patients want. So where we're going, like I said, the practice in the Twin Cities, the Bluestone Physician Services practice, is what we consider our sandbox. And as we take this model to other markets, we plan to continue to develop and innovate in the Twin Cities model. And areas where we see opportunity are things like activity monitoring. Certainly, understanding what types of activities are impacted when people begin to get ill, or if we can apply monitoring to keep people safer with less supervision in the home environment, for instance, with dementia. I think these are some interesting things that are being explored now. We don't really know where the value of those is, but we're interested in continuing to explore technology and monitoring and how it might inform us to be able to be more resource intelligent about how we monitor this population. And one of the things we struggle with is having too much information can also be a problem. And so you're trying to sort out what's noise and what is valuable information. I think that's where the work is right now. The other aspect is efficient support service distribution, which really gets into using these technologies to bring in medication management or behavioral health or these other services on site and improving the efficiency of the providers of those services. When I was working at the Fairview Health System, we actually measured the medication management team's productivity in the clinic and then added the ability for them to serve patients in the virtual setting as well, and we saw a huge uptick in their productivity because of the ability, if the patient didn't come for an appointment or if they had an opening in their schedule, we were able to make them available to another person who needed the service, but we made it available through the internet, which I think is a great way to think about the fact that we have limited providers, we have a burgeoning population. We've got to think about ways to improve the efficiency of how these services are distributed, and I think that applies to medication management. It certainly applies to behavioral health, and it really applies to many specialty services that these populations need. And then the operational efficiencies, we're constantly looking for ways to improve the staff and our providers' operational efficiency. For instance, I currently dictate notes into the memo section of my iPhone. They're not identified with any patient data. We have a way of doing that, but then I can email the memo, dictated memo, as an audio file to one of my colleagues and the team coordinator, and she can actually enter information in the note based on that memo. And as long as we really pay attention to the HIPAA issues there in terms of not having patient-identified information, this can be a great way to be very efficient about getting information about a family conversation or other ways of getting information into the health record that are much more efficient than me pulling over and trying to type something or find a terminal and get onto a website and figure out how to get this all entered. And I'm able to also do a better job of actually putting a narrative in the note. And I think that some of the documentation systems may be efficient in terms of hitting a button and a bunch of stuff gets entered. But as a clinician, what I end up with is a list of things that don't tell me the story that matters. And I think narrative documentation is an important part of care when we get into this part of the spectrum, because there's lots of nuances that you can't capture in a checkbox. So again, these kinds of efficiencies, new technologies are coming on that are not expensive. They're widely available on iPhones and iPads and other tools that we work a lot with and test and try to figure out what is efficient, what is appropriate, and how do we best do that. The other thing that we're working on, as I stated, is really extending this model to more patients in other markets. So we're in conversation with markets in other states that we think have a need, and we think that our model can really help a health system or a health plan or an independent physician group really become a key component of the delivery system. So we have packaged up, so to speak, what we've done here in the Twin Cities and are now working with other partners to bring this model to more patients. We don't have a desire to employ 1,000 physicians. What we'd like to do is continue to use our physician services practice in the Twin Cities as a sandbox and then help other organizations be successful serving this population. Then I think the really important development is I think we're going to need some new payment models. I think today's payment model, which pays a lot for people who don't use health services so that we can pay a lot for people who are using too many and try to recruit people who don't use services into your health plan at a greater pace and try to not serve patients who are using a lot and decrease utilization is not the way the payment model should work. It really should be designed around applying the right services to the populations that need them and rewarding providers for doing that really, really well, which is not how the model works today. And so, again, again, I think there are going to be some payment models. We're really trying to understand what are our costs, what are our true costs for serving this population, and what is a payment model that will drive the right kinds of care, and how do we measure effectiveness from a quality and a total cost and an experience perspective, and how do we align incentives so that we get that done the way it needs to be done. So I think we are done with what I would say is our formal presentation. I think we've got about 15 minutes for any ongoing discussion or questions. Trish, are there any more questions that have filtered in?
Nothing at this time.
All right. Anybody want to type quick and get a question in for us?
Dave, this is Chris Norton, Director of E-Learning for the PCPCC, and thank you very much for your discussion today. That's very informative how you're actually bringing the elements of patient-centered medical homes directly to where these critical need patients are. A couple questions that I did filter out of the question box, and maybe we can try to get through some of these before the bottom of the hour. You didn't want to tell too much about your predictive care model, and I can understand that because of some IP issues, but can you tell us a little bit how you're actually validating that model?
Basically, we are looking at Bluestone population and non-Bluestone population and trying to determine the impact of our model with regard to quality and cost. So a matched population that we aren't caring for and comparing the two.
Okay, that's good. You mentioned the emergency department is kind of one of the weak points. Once patients leave your facility, they're often going out into an unknown territory. How are you actually communicating with the EDs, and also are you able to generate any continuity of care records from your amazing charts documentation that can follow them?
We are in the process of building all that out. What we're staying in line with is the meaningful use requirements. We think that it's better to align our efforts with those requirements because the industry itself is being forced, if you may, into a different way of thinking about exchanging information. So we are right along the meaningful use pathway. So we can generate the CCDs today, and we're able to share, and we're preparing to receive, and I think that's where most people are. We do have, when our patients go in, our contact information goes with them, and we do have a more comprehensive medical record, I think, than I'm used to receiving as an emergency physician. These patients, because they're seen monthly, and because they have really this more comprehensive approach, I find the paper documentation that is available at the facility is accurate and up-to-date and more comprehensive than I'm used to seeing. I was used to seeing as an emergency physician a sheet of paper that might have 3 or 4 things on it and a med list that could be right but probably wasn't, and half of it was in the daughter's purse, scrawled on a sheet of paper. And as an emergency physician, I was really limited in terms of my ability to reconcile all that. And so what we try to do is make sure that our electronic documentation certainly is there for those who have access to it. But we also have paper documentation, and we really make effort to reconcile the medication list and make sure that there's actually narrative about the key problems that are going on, and that we really have documented, well, what are the family wishes, what is the care plan, what are the patient's goals, what are we really trying to accomplish here, which I think is as an emergency physician was always the difficult thing to try to figure out, unless you were lucky enough to have the daughter who really knew everything there in front of you, which didn't always happen. So we're just trying to build forward with everyone else. I don't think we're necessarily ahead of everyone else in terms of how our EHR part of our system works. I do think we're ahead in terms of how we've enabled communication among the team members and how we've reconciled the chart to a different end game.
Great. One step at a time, and it sounds like you're on the path. Tell us a little bit about conferencing capabilities with family members. I know that's one of the highlights of your model. And is it all telephonic or using other technology means of outreach, such as FaceTime or same time and video type activity?
We use telephonic or webcam video like FaceTime technology. And what we've found is the face-to-face piece is really important, both in terms of services like, for instance, interpretive services, which we can bring in face-to-face, or pharmacy services. There's something different about being able to see the person on the screen and have a conversation as opposed to having it over the phone. And so the technologies we use really cover all those venues, and it really depends on the family members' access. And what we're finding is more and more family members have access to webcams and other FaceTime, other types of technologies that make this pretty easy for us to build that in.
Great, thank you. What's the typical size of a panel of patients for each of your care teams?
About 600, I would say, would be an average.
Great. And how do you integrate other services like behavioral health and pharmacy into the team structure?
The physician that's the primary care lead on the team, it's really their responsibility. One, to determine if there's a need. Two, to choose the type of need, meaning do I need a psychiatrist actually to come and see the patient in the facility? Is this something we can do virtually? Or do I need to just talk to a psychiatrist during our case management part of our practice about what I'm experiencing and then carry out the plan without them seeing the patient? So it's really that physician's responsibility to determine what level of support they need. And that applies to pretty much all the support services that we bring in.
Do you actually contract with each facility then, or what's the reimbursement structure with the facility?
So we contract to provide services. We don't get paid to be there. So our revenue comes from the fee-for-service reimbursement that's afforded in the model, and then again, with some plans we receive additional per member per month payments because of the fact that plans have realized that this model is reducing total cost, and they're willing to pay us care coordination or medical home fees on top of fee-for-service to support the model.
Okay, great, thank you. Do your predictive analytics actually help you anticipate the care that patients are going to need, or how are you actually utilizing that at the point of care?
I think what they do is they help us intersect with the population at the right time. I don't think we're sophisticated enough from an analytics perspective to predict the kind of care they're going to need. I think what we can say is that we can tell what types of utilization are typical at various stages of dementia dementia or frailty. And we also have a point of view and have developed expertise around what types of interventions are important. What's most interesting to me in that realm is that at least half the time in this population, the interventions are social. They're not medical. And I've learned, which took a while being a doctor, how important nursing and social services is in terms of how those disciplines think about care and the skills they bring to the plate in terms of facilitating family conversation, understanding what kinds of support can help a patient in the setting. As a physician, I just wasn't trained to look at a situation like that, and I found the most valuable part of this model is that it's interdisciplinary. And we try to be as non-hierarchical as possible in terms of understanding perspectives that team members have and really honoring the professional judgment and expertise that multiple players bring to the table. The physician's job is really to enable that kind of interaction to happen. Whether it be the facility staff feeling comfortable and empowered to call if they feel something's wrong and not be scared to death of the pain in the rear doctor on the other end. So we try to establish an environment of respect at all levels of the model. And I actually believe that is the key to success. And this model doesn't work if it's hierarchical and people like social workers or facility staff or nurses or pharmacists don't feel empowered to share their judgment and offer their perspective and advocate for what they think needs to happen. And I actually think our profession, and I'm talking about broadly our profession, nursing, physicians, et cetera, have a lot of work to do to break out of the hierarchical mindset that I think really chains us to not unleashing the full interdisciplinary power that is at our disposal in these situations. We find often families are not as comfortable talking to the doctor as they are to the person at the facility. And the person at the facility has key information, and if they feel that they can't tell us something or they're afraid to talk to us, we don't get that information. I found it extremely helpful, for instance, when going into a memory care to just ask all the staff to come together for 5 minutes for a huddle, and I want to understand what's going on in that setting and what I need to pay attention to while I'm there. And it's been such a switch from my emergency medicine place with these patients to be able to have access to that information. It really shows you an entirely different spectrum. I'll give you an example. We had a family member who was concerned because they thought their mother, who was on hospice, was over-sedated. And, you know, if I had just read everyone's notes and talked to the patient who's terminally ill, I would not have known that concern. And it happened to be an aide that had talked to the daughter the day before on a Sunday. And I was there on a Monday, and having access to that information, I could call the daughter and ask, you know, what her perspective was and have an important conversation about her mom and where she was in the continuum. Again, I would never have access to that until it hit a crisis of some kind and somebody was really upset or, you know, something happened. But if the staff don't feel empowered to share those things, then we don't get access to them and the patient suffers.
Yeah, that's so important. We still have a lot of opportunity to shake up those old paradigms, don't we?
We do.
Well, Dr. Moen and Trish and Hope, on behalf of the Patient-Centered Primary Care Collaborative and the Center for Care Delivery Integration, I want to thank you all once again for your very wonderful discussion today about how you're actually able to deliver continuous and comprehensive care to underserved population who's in critical need. And to the audience who's been participating, thank you as well for sharing your time. I want to remind everybody that the slides and the recording from today's session will be up on the pctcc.net website within the next 24 to 48 hours. So with that, I'd like to wish you all a good day.